Lung isolation techniques, my favorite topic. If any time during the presentation you want to stop to see some of the slides, please do so. Most important tool when you do lung isolation techniques is a fiber optic bronchoscope. There are self-contained units and units like this one that come with a camera that needs to be attached to the bronchoscope and a big viewing screen which gives you a higher quality image. The airway anatomy is fundamental that we have a good understanding. Here we're doing a fiber optic bronchoscopy through a single lumen endotracheal tube. And as we exit from the tube, we see the longitudinal fibers in the back wall of the trachea, the rings and the top, left and right bronchus. You can see the takeoff of the right upper lobe. We're going to enter the right bronchus and go into the right upper lobe and see the three segments of the right upper lobe. And then the bronchus intermedius and the middle and lower lobes are clearly visible. The relation between the carina and the right upper lobe is very important to keep in mind when you use bronchial blockers. We're going to enter the left bronchus, which is usually around 5 centimeters in length in the adult. You see the two lobes clearly visible, their entrance. So using the blockers on the left side is very easy. On the right could be a little difficult. Longitudinal fibers again, tracheal rings in red, the right and left bronchus, and right upper lobe takeoff in red arrow to point in the carina. This relationship is very important when you use blockers on the right side. And for this presentation, we are using a dummy. So we're going to do a bronchoscopy of the tracheobronchial tree of our dummy. Longitudinal fibers, left and right bronchus. This dummy does not have a right upper lobe, and that is a limitation of this presentation. Notice the angle on the left bronchus takes off. Well, we'll start with bronchoscopic confirmation of endotracheal tube position. And you can see through the tube the dummy's airway. You can see his teeth and the oropharyngeal tissues, even the uvula and the glottic opening and entrance. And this is important because sometimes through the tube we can see the anatomy of the patient and get an idea where is it we are. As we emerge from the tube, you see the relationship between the tube tip and the main carina. And if the tube is too far in, like in this case, it's easy to use a bronchoscope to position the tube appropriately and make sure it's not too far in. There are different techniques to isolate. It could be blockers or double lumen tube, and even the Fogarty catheter can be used. The diameters of different tubes, single lumen, univent, and double lumen tubes are in this slide, and you should take time to see the slide in detail. Right-sided double lumen endotracheal tubes anatomy, as you can see, has a Murphy's eye, the bronchial ending, which is the blue, and it has also a distal opening. The cuff is shaped in a way that will facilitate blocking the right bronchus, and it has a distal ending, yellow is a Murphy's eye, and then the red distal bronchial lumen, and black the tracheal lumen, a thin black arrow. We do a bronchoscopy through a tracheal opening of a right-sided double lumen tube. Place the bronchial lumen inside the right bronchus. As you can see, the cuff is not visible, so this was probably a little too far in. It will be pulled out a little bit so you can see part of the cuff. And then bronchoscopy should be done through the bronchial lumen to confirm that the Murphy's eye is in front of the right upper lobe. That way, the right upper lobe is not blocked by the right-sided double lumen tube. So I said we will not present this as a limitation of our mannequin. We're now doing a right-sided double lumen tube, placing it through or over a fiber optic bronchoscope. The bronchoscope is in the right bronchus. The tube is slid over. As you can see now, the tube is in the right bronchus, and at this time we should take a look at the Murphy's eye to see its relationship with the right upper lobe to make sure they face each other. Left-sided double lumen endotracheal tubes are easier, almost always placed instead of the right, as there is a little more difficulty to place the right tube. The left side has an angle in the bronchial lumen. It has no Murphy's eye, two openings, distal and red, and then the tracheal opening in black. Almost always a left-sided tube is placed instead of a right-sided, unless there is a contraindication to a left-sided tube. We're doing now bronchoscopy, placement of a double lumen tube with the bronchoscope through the bronchial lumen. bronchoscope will go into the left bronchus and the tube will be slid over. Normally, double lumen tubes are placed initially blindly and then position confirmed by auscultation and ideally with bronchoscopy. Now we're going to take the bronchoscope through the tracheal lumen and see the position of a left-sided double lumen tube. So you can see the cuff is a little too far out, a little herniating into the trachea. The tube will be pushed in with the cuff still deflated, and then the cuff will be inflated. This will be the ideal position of a left-sided double lumen tube. The cuffs are inflated only until there is no leak to minimize the tracheobronchial damage due to overpressure. And the bronchial blockers, there are several options, including Fogarty catheter, not depicted here. Cohend, Arndt, and Univent. Univent, as you can see, there are two versions. One that has a Univent tube and a single Univent blocker that can be used as well. There are two versions of the Univent tube. This probably no longer can be found in the market, in which the blocker, as it emerges through the Univent tube, has poor torque control. The Univent tube, as you can see, is a double lumen tube in which it has one lumen for a blocker and one lumen to ventilate the patient. The problem with that is that the ventilatory lumen is smaller than the outer diameter tube. Here we have a bronchoscopy confirming that the tube is not too far in. We usually do bronchoscopy. Now the tube has been advanced too far in. We're going to pull it out to the proper position. Then the tube should be secure and then the blocker deployed. Now once the tube is secure, the blocker is deployed under bronchoscopic guidance, and we're going to put it first in the right bronchus. Univent blockers are a good alternative for lung isolation. All the blockers have an inner lumen that can be used to then put some suction if needed, or do a little CPAP if necessary. We just leave it open so the lung deflates. So you can see, easy to put the balloon up, and now we're going to try to rotate and see poor torque control of this first version of the Univent tube. And we're going to rotate again until we align it to the left bronchus. One trick when you're placing blockers, now we got into the left bronchus, is to actually rotate the head to the opposite side where you want the blocker to go into. This will align better. So if you're doing a left blocker, you turn the head of the patient to the right, and that facilitates the entrance of the blockers to the opposite bronchus. So face to the right for left blockers, face to the left for right blockers. So the right blockers are usually a straight shot, not a problem. Another trick you can use is put the endotracheal tube on the left oral commissure for left blockers, or on the right oral commissure for the right blockers. Second version of the Univent tube, you have much better torque control. As you rotate proximally, you see how the blocker translates the motion in a smooth fashion. It's easier to control. Notice always, though, the ventilatory lumen of the Univent tube is much smaller than a corresponding tube of similar size of single lumen tube. Again, bronchoscopy, tube to main carina relationship confirmed, the tube is secure, and then the blocker is deployed. I like to inflate the blocker's balloon under pressure control ventilation, realizing that when you occlude one lung, if you occlude the right lung, the tidal volume will decrease to a little less than half, and if you occlude the left bronchus, the tidal volume will decrease to a little more than half. That way I minimize the pressure in the blockers and risk of bronchial ischemia. Blockers are ideal. As you can see, this is a well-positioned blocker. When you do want to keep the patient intubated at the end of the case, and for all our minimally invasive cardiac surgery, the knees lung isolation, we use blockers unless the takeoff of the right upper lobe is higher up than the carina or at the level of the carina. Then we have trouble placing blockers. I'm talking about right-sided blockers. For left-sided blockers, it's usually no problem. It's easy, thoracic surgery or thoracoabdominal aneurysm, etc. Blocker in the left bronchus is too far out. We'll probably advance it a little bit more. Always remember the blockers can fall into the trachea and cause complete airway obstruction. One issue to always keep in mind: if you see a sharp decrease in the tidal volume or a sharp decrease in the airway pressure, always consider blocker herniation into the trachea, and total airway obstruction is a possibility. Univent blocker through a single lumen tube. Notice the blocker adapter. This is ideal. Yellow the bronchoscope port, red the blocker, and blue the actual adapter. So using an 8.0 single lumen tube, we can place this blocker easily. It is always important to consider the diameter of the tube adding the bronchoscope. Arndt blocker, excellent alternative. It has that proline loop through which the bronchoscope will be placed through. This is all blockers have centimeter markings, proximal portion, adapter for the Arndt blocker port, bronchoscope port, and then the T vertical portion is where the airway breathing circuit will be connected. Bronchoscope through the proline, and then the blocker will follow. The beauty of this blocker is that it has 3 different sizes, 5, 7, and 9 French. Here bronchoscopy, we're going to put the blocker in the right bronchus, place the bronchoscope down in the right bronchus, and then the blocker is slid over as it emerges in front of the bronchoscopic view. You will see the proline emerging very soon, the top portion of the screen, and then the blocker will follow as we continue to advance the blocker. Here we go, proline and blocker. We then hold the blocker in that position and withdraw the bronchoscope to assess final correct position of the blocker. As I said, there are 5, 7, 9 French sizes, and this is the beauty of this blocker. Univent and the Cohen blockers only come in 9 French. Ideal blocker also to be used. It can be positioned on the left side. Sometimes the proline gets hooked in the bronchoscope, and there could be a little bit of difficulty doing that. A trick that you can use is you can take the blocker and actually bend its tip. The blocker has some memory, so only will last like 5 minutes. It's bent, but then you use it as a univent blocker and rotate it and actually position it. It's patient with the blocker in place and the adapter. Excellent blocker. Cohen and the bronchial blockers has a problem that the balloon is very big in relationship to the blocker and does not deflate completely flat to the blocker, so it can obstruct your way or your view. Here you see the tracheobronchial tree. The blocker will be deployed first in the right bronchus, and we'll advance the blocker, and you'll notice how the balloon takes a lot of our view, and in a smaller airway this could be an issue. The blocker being advanced in the right side. This blocker has a little wheel at the top that as we rotate it, the tip will bend following this black line you can see at 9 o'clock position. See also how the balloon tends to herniate on this blocker. That's another problem of the Cohen blocker. Another alternative though. Always remember Fogarty catheters could be a useful alternative, although they don't have a lumen through which CPAP can be applied or suction can be done, or to facilitate the emptying of the lung. You can also empty the lung though by putting the blocker in the lung, disconnecting from the breathing circuit, detaching the patient, as I said, from the breathing circuit, and then inflating the blocker, and then reconnecting to the breathing circuit. So Cohen blocker in position. Excellent alternative as well, but our least favorite of the 3. Univent single blocker is our favorite. And of course the balloon tubes continue to be the kings of the lung isolation techniques. Blockers can also be placed outside of the endotracheal tubes in smaller patients. It's something to consider as an option. I hope you enjoy this video, and thank you for watching.